Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today, we're going to do another shadowboxing episode. If you didn't hear the first one, shadowboxing is an idea suggested by Gary Klein, in which you hear cases or, in non-medical world, situations presented to experts, and then you hear what they do. But the key, the magic of shadowboxing is that there's a pause where you stop to consider what you would do, and then you see how closely aligned you are with the experts, or the alleged experts in this case, because I'm involved, and see what you would have done differently, and whether they're right or you still think you're right. And so these are not complicated cases. These are bread and butter resuscitation. And yet, what you'll find, and what I continue to find, is there's so much to talk about in these bread and butter cases. Now, shadowboxing is free for learners of all types. It's specifically made for learners in the residency category and new attendings. But I promise you, unless you're doing resus as your main career every single day, you will learn something from these shadowboxing episodes. So, no interruption, free the entire time. Today's case couldn't be more bread and butter, and yet we have 45 minutes worth of conversation that I think will be super interesting and helpful to your knowledge base. Now, this is free, and the only way that happens is from the support of the actual members. So if you already are a member, thank you. This would not be possible without you. If you are not a member, please consider joining. If you're an attending, this is some of the cheapest medical education out there. If you're a resident, we're talking 2 cups of coffee per year, which your residency should reimburse you for. Now, we are working on a deal to get interns free EMCrit. I'm working on that right now. I don't think interns should have to pay anything. That's in the works. But please, if you're not already a member, consider joining. All right, let's jump right in. Now, I have my previous guest on shadowboxing, Ryan Barnacle, one of my previous fellows. He's over at Yale. Joining us new this month is one of my all-time faves, Christina Liu. Love you, Lou. And she is in Hartford. She's organized the case this month with our case presenter, Lucas Goss, chief resident at Carolinas. And let's jump into it. Lucas, tell us a little bit about yourself.
So I'm at the end of my second year at Carolinas Medical Center doing emergency medicine residency. Currently going to be applying to internal medicine-based critical care fellowship this summer.
All right, very cool. All right,
Yep.
Lou, what are your current titles? What's your official?
I am Associate Director of Emergency Critical Care and Associate Director of our Emergency Critical Care and Resuscitation Fellowship at Hartford Hospital.
Beautiful. And Barnacle, any changes in your list of impressive
No.
credentials?
Core education faculty with the residency at Yale, emergency medicine.
So then let's get right to it. Lucas, you seem to have a case for us. Now, this case to protect the innocent has been changed from the actual case, and to allow myself, Ryan, and Christina to really be flamboyant in our disdain at times, you've actually made the case worse than it actually was in real life. So no one who actually was involved in this case should feel any negative emotions if we lambast the care, because it's not actually what you did. All right, fantastic. Go into it, Lucas.
All right. So we did not receive a call ahead of time for this patient coming in. It was a busy weekend day, and EMS arrived with a mid-40s-year-old female. They roll her into a resuscitation room, and she's on a non-rebreather and obtunded. The report by EMS was that a family member found the patient unresponsive on the floor. They were able to tell us that she has a history of heart transplantation, insulin-dependent type 1 diabetes, and is unvaccinated for COVID. And she's been feeling ill for the past 1 to 2 weeks and was diagnosed with COVID last week. She's been experiencing shortness of breath, weakness, and then progressive confusion, slurred speech, and now multiple episodes of emesis. Vitals for them were highest heart rate was 141, lowest blood pressure 91/57. They haven't been able to obtain oxygen saturation at all on her yet, and she's tachypnic to 40. They gave her a GCS of 8. They checked the glucose. It was unreadably high on their glucometer, and they essentially placed her on a non-rebreather just due to inability to attain oxygen saturation. Multiple attempts at IV access for them were all unsuccessful.
So how does she look when she rolls in?
Yeah, so rolling in the room, her eyes are closed. She's laying there. She's not moving. She's tachypnic to 40s, just like they say. When we initially assess her, she is responsive to pain, but not answering anything to voice, not opening her eyes to voice, not following commands at all. Extremities cool to touch just on the initial exam.
Okay. So I think this is a nice place to stop as far as what are your initial impressions? Lucas describes the patient, they're hypotensive, tachycardic, questionable if they're hypoxic, and high glucose, no IV access. What are your impressions just going in on this patient when they first roll in, and where do you start?
All right, here's our first shadowboxing point. What are you mentally picturing on this patient, and what are you thinking you're going to do next? Why don't you start, Barnacle, and then I'll add my thoughts.
Sure. So I guess first things first, GCS of 8. There's like a bad GCS of 8, and then there's an acceptable GCS of 8 where I can wait a little bit before taking the airway. So that's what I would want to assess first. Regardless, we're going to need access if we're going to start resuscitating and potentially intubating this patient. So I'm going to look at my team and see, is this a quick IV access I can get, or do I need to put in an IO? I suspect that the difficulty obtaining a O2 sat is related just as much to her peripheral perfusion as it is probably to her oxygenation status. So I'm going to empirically treat that as if she's hypoxia. The non-rebreather is a good start, but if we don't have non-invasive available in the room, that's something I'm going to want to be calling for. And then if I do have a team member that can start preparing to intubate, I'm going to have them set up to do that.
All right. So much good stuff there. Don't necessarily disagree with any of it, though I have a slightly different spin on most of the things. So I like your idea of a good GCS 8 and bad GCS of 8, but the break line for what that is, are they protecting their airway? Now, there's this idea in emergency medicine that GCS mandates intubation, and that's a real derivation from what GCS was originally intended for, which is it's a coma scale for patients with brain injury. So if you have someone who's GCS with a traumatic brain injury or a hemorrhagic stroke, for instance, that probably is a patient that needs to be intubated. The applicability of that GCS to things like tox or a patient like this who's in the undifferentiated zone, yeah, if she stays at a GCS of 8, probably eventually we'll intubate her, but it shouldn't mandate care right now. So I completely agree with you on that, Ryan. And so the question then, is she protecting her airway? Don't do something stupid, like look for a gag reflex. The question is she managing secretions? Does she seem to be breathing about stridulous sounds? And if so, then we got some time. And sure, I got no problem with a non-rebreather, but I'll take what you said a step further. If I can't obtain a SAT, it's never a respiratory issue. Respiratory issues don't cause SATs you can't obtain. They cause SATs that you can obtain that are crazy low. And in fact, you'll see during CPR sometimes without compressions, there's no waveform. You do compressions and they'll have a 95% SAT. And then counter to that, you'll have some of these COVID patients who they are the worst patients with hypoxemia you'll ever see, and they'll have SATs in the 30s. Now, is that SAT accurate? No, it's probably not actually 30%. And we showed that with ABG matching. But the point is, hypoxemia is demonstrated by low SATs, not the absence of a SAT waveform. So sure, put them on a non-rebreather. Would I have non-invasive in the room? Sure, why not? Though I think in a patient like this, I don't really think it's a lung issue. Their lungs are clear. So if I needed something non-invasive to temporize for intubation, I'd probably just use a PEEP valve and a BVM and not waste respiratory's time on this, especially with their busyness during COVID. I'd probably just say if I needed it, I'd use that. But my guess is if I improve this patient's cardiac output, then I'm going to see a SAT waveform that'll be reasonable. The last point is, and I agree with you, patient's probably showing signs of poor perfusion, but in counter to our previous shadowboxing case where it was a patient with poor heart function and vasodilation, this patient seemingly extremely vasoconstricted. She's cool to the touch. She is not perfusing. She's hypotensive and tachycardic. And it all fits with an incredibly high glucose. And whether that turns out to be a ketoacidosis or simply a hyperosmotic hyperglycemic state, in either case, the patient's incredibly fluid down. So in contrast to the patient in the previous cases who were afterload reduced, who I might give vasopressors and inotropes, push dose epi. On this patient, I think we need to get in fluids ASAP. And you alluded to that, Ryan, with your need for immediate IV access.
And so I think an interesting thing he said was that EMS, multiple people tried to get access and they couldn't. And I believe, and I jump ahead, but it sounds like they tried ultrasound guide IV into one of the deeper veins, basilic or cephalic, and it blew. Is that right, Lucas?
Yeah, that's correct. We essentially had two nurses, each arm, both with ultrasounds, trying ultrasound guided IVs while we were drilling an IO. And she did seem to respond with that. And I guess I'll comment a little on the protecting airway because I didn't comment on that before. She's definitely not gurgling on secretions. There's no stridor. She had been vomiting, her family's report, but no vomiting in the room or retching or anything like that. And really, Dr. Weingart said, clear lungs as well, and no signs of cellulitis, infection, or anything like that on the initial exam.
So I think for this, and that's another interesting point about this case, is that how do you go about obtaining access?
All right, so let's shadow box right there. How would you obtain IV access on a patient like this? Take a second to think about it and then go on.
So we know a lot of these deep IVs, I know you say you jumped ahead, we went to IO, but in this patient, where would you start when a lot of these deep IVs, they blow, and that's not surprising? What are our options?
In this patient, initially we went for the ultrasound guided IVs. We actually were able to obtain one, which they drew labs on, and we started infusing fluids. And just like you said, they're prone to blowing, unfortunately, especially when you put them in like a basilic vein. And that is exactly what happened. And from there, in a patient with suspected DK or HHS, for me, I knew she was going to need insulin drip, likely electrolyte repletion, fluids. I knew we had to get multiple points of IV access, essentially. So for me, that immediately indicated I needed to put a central line in.
You want to comment on that, Ryan, or you want me to start off?
Yeah, there's no problem with putting in an IO, even more than one IO, if that's what you need to get things moving. But with my approach to these patients, it's hard to do the resuscitation I want to do without IV access. And so if even an ultrasound guided IV is proving difficult, I would just look at like my most seasoned resident or myself to just put an ultrasound guided central access in. Either probably femoral in this case, just because it seems like the chest is going to be a busy area, or I've started doing a lot of ultrasound guided subclavians as long as it's like a clear shot. But to get things going, I don't think there's anything. I would never fault anyone for putting in an IO. That's like our backup of all backups.
Yeah, I agree with those comments. I will put out there that I think you should think of an IO as a bridge to medications. And so if you need an immediate intubation or you just need to get pressors in or inotropes, then an IO is really the money and it'll get that job done. It, in my experience, is not a fantastic line for continued reliability or for large volume infusion. Now, there are people that'll tell you, oh, we'll just put in 2 humeral IOs, and that's going to be our blood resuscitation for an exsanguinating trauma patient. And more power to you if that's all you can do. I don't buy it. I don't like it. As soon as the patient moves those arms, there's a potential for them to get dislodged. So in this case, yeah, absolutely start with an IO. I don't think I'd be messing around too much with ultrasound-guided IV access for more than a minute or two. The beauty of getting good at resuscitative lines is you should be able to put a femoral access in this patient dirty in less than 3 minutes. It probably could be less than that, but I think 3 minutes is a very nice marker. And that's where you should go. And since it's dirty, and I don't mean dirty as in rub the catheter on the floor and lick your ultrasound probe, but just not full sterile. Put on a probe cover if you have them immediately available, and you probably should put on a probe cover anyway to avoid contaminating your probe. Swipe with the ChloraPrep stick and then throw down whatever crap-ass drape is in the central line kit with a pair of sterile gloves on and get in a femoral line. Now, since it's dirty, it's going to force you to then ask yourself later on in the case, where should we go from here? We probably shouldn't send them up with this dirty groin line unless that's what your ICU is cool with, and they'll take care of it and put in something clean. On a patient like this, we would put in a midline later on, full sterile, and have access that we could just pull the femoral line or keep the femoral line, but no, we'll tell the ICU, pull it in 24 hours. And I think there's this barrier, and I've been part of the establishment of this barrier of we have to do lines full sterile. And that's never really the message. The message is you only have 2 choices. It's full sterile or dirty. And it's that dichotomy that I need to get across to people is you can either do a perfect interventional radiology quality degree of sterility, or everything else you do is dirty. And since everything else you do is dirty, then you might as well get the line in as quickly as possible. It's relatively clean, and now have access. And I like what you said, Lucas, that a triple lumen makes a lot of sense in this case. They're going to need a lot of infusions. My guess is they're not bleeding. So I don't think I'm going to need a cordis or an introducer if we put the common vernacular onto it. A pressure utilized bag or even a level 1 on a patient like this with fluid through the 18 gauge port of a triple lumen, it'll get the job done. Will it be as quick as a 8.5 French cordis? No, but I think this patient will turn around relatively quickly if what it seems initially is actually the case with just 1 or 2 liters pressure bagged in as rapidly as possible. So yeah, I would put a central line in this patient. I'd have that being done simultaneous to an IO, and at some point in the case, we'll replace that with clean access.
So you wouldn't start with a midline? Is it just too much time? Like, would you just put an IO and then do a midline at the same time? Or
I think there's few people out there that are quicker at midlines than I am, and it still takes a while. It's still more steps. It's a lot of steps. And you could get them done quickly. I would not do a midline in a patient who doesn't have actual IV access as salvation line. Now, sometimes we'll have a crappy 22 gauge, we'll start our norepi on, and then I have no problem running that for 15 minutes while I put in a midline full sterile. But it's not nearly as quick as a central line.
I think we should just comment about using ultrasound guided, even quote unquote long IVs in the upper extremity for resuscitation. In my experience, if it's a patient with just difficult access and you need to get labs and give a dose of antibiotics, those are usually fine. You take your time, you get the room set up, you put it in, you tell them not to move their arm too much, and you get the job done. But like they alluded to in this case, it's just so unreliable as a resuscitation line with the patient moving around. I know you've talked about that before, Scott, with just how kind of these things come out a lot. What are your thoughts on that?
Yeah, Lucas, which kind do you have in the ED this case was actually taking place in?
Oh,
we have these Arrow 18 gauge angio catheters. They'll be linked in the show notes, I believe, but they're 2.5 inches long. And then we also have these 18 gauge catheters that are just under 2 inches long. And we typically, especially if we're going in the upper extremity for basilic or something like that, we use the Arrow angiocasts that are 2.5 inches long.
And are those a Seldinger? Are they a one-piece wire? Are they just an IV catheter? What are they actually?
So it's the needle and then the catheter essentially surrounding the needle, and needle goes in and then you just thread the catheter over the needle.
Okay, so it's just a regular IV catheter that happens to be.
Yeah.
I agree with Barnacle on this. On a patient like this, I probably would not mess around with ultrasound guided IVs. Now, the kind that first one you described, yeah, it's probably long enough. It's probably, if you're actually going to be relatively durable, it's not as bad as some of the shorter, quote unquote, long IVs, but I don't know. I don't like it. I don't like on a patient who's critically ill not having access that I could really trust, especially if I'm going to be pressurizing fluids into the patient. So if you get it, great. The thing is, what happens is there's a high dicking around factor with this, and people are trying and trying. What I would love is start the dirty femoral line while someone wants to get ultrasound-guided IV access. And if it turns out we get both, that's all money. If it turns out they beat me and I already have a wire in the vessel, then I'm just going to put in the triple lumen anyway. And then we have something to fall back on, right? If that line turns out to be good, then I could just pull my femoral line if we could get like a second IV access at some point. Or that ultrasound guided line becomes a midline, which, we haven't published on yet, but we did most of our recent midlines by converting an existing upper extremity IV. For me, I got no problem, with that, but it would not preclude the simultaneous placement of a central line for me.
Yeah, and just for a fun fact, because this is actually a debate we're having in my ER right now, we actually have IV therapy. But so we have this debate between us and IV therapy. And so we looked into the data, what historically is there. And I think if you go from the elbow below, these really shallow ones, you get ultrasound IV, they stay for a very long time. But I think once you go into the deeper ones, it was something like 50% fail in 12 hours.
Yep. Absolutely.
In deep veins. And
I
so
think that's fantastic evidence.
Yeah.
What we can say is if it's actually in and you convert it to a midline, you're going to be golden. And that's something that hopefully more and more hospitals will have access to. Now, you were asking me at some point, Lou, about EJs.
Oh, yes.
I'm curious
That's
to
my
hear what your
favorite
feelings
line.
are.
For me, I always look. There's something so satisfying by pulling them in, but also I find that they're really dependable. You can get them very quickly. I think I don't think we're using it as much as we could be for EJs. As we go to IOs very quickly, but I think you should always look for EJ. It's right there. you tilt the patient backwards or Trendelenburg, you occlude distal, and if you see it, it's great. And just for fun, lately, one of our nurses showed me we have IV finders too, and you can just show up blue just as a cheat. But I think it's a super easy line to get, and it's always worth looking for.
Okay, folks, what are your feelings about external jugular IV lines? Give it a thought, and then we will get back to it.
Yeah, I remember a couple of attendings that I trained with. Love the EJ. If it's there, I think it's a good place to start, but this patient's going to need more than that.
Yeah, I hate EJs. I think they're a garbage line. So hopefully I'm not offending you too much. They're from my experience, and again, those are the most dangerous words in medicine, but from my experience, they blow. Yeah, you get them quick. They're super satisfying. They don't last. It's probably because there's back walling. You don't get an actual flash very often on EJs, or if you do get the flash, it's delayed because it is very much like the IJ, a negative pressure vessel a lot of the time, unless they're in extreme Trendelenburg. And so I find that, yeah, you get something in and you can pull blood back and you feel all good about yourself, and then the neck blows up. I don't like it. If you were going there, I think you're better off doing a technique that I'm not a huge fan of, which is actually just putting an IV in the IJ under ultrasound guidance. Now, I think the better way to do that, if you have them, is micropuncture kits. And the quickest line in the world is just put a micropuncture in the IJ. And for people that are not familiar with this, is a 23 gauge needle, a thin wire that then converts to a 10 centimeter 18 gauge catheter. There's an internal dilator. It comes out. It's Seldinger if you buy the right kits, and it's quick. You can get one of these in 30 seconds, and now you have an 18 gauge in the IJ. You could totally fluid resuscitate through. You could give all the meds you want. And now this is where it gets a little gray zone, but I think it's okay if you put a wire through that and then re-sterilize the whole site. You sterilize twice. You sterilize over the existing micropuncture in the IJ, and then you take it out, and then you re-sterilize again with a second ChloraPrep. I think you could probably call that a full sterile central line.
So I'm not sure what you guys ended up doing, but the one thing I would also add is if you're at the groin putting in a central line, I would probably just put an A line in at the same time, because this patient, we're wondering how reliable that blood pressure is. I'd like to just take that off the table and get a waveform.
So that's Josh Farkas dubbed that the dirty double. And yeah, I think that's a great way to go. And the idea is you could just have the site sterilized once, you pop it in, you ask someone to open up an A-line kit for you, and then you pop that in.
So I guess moving on, central line is king, and then we'll move on then midline. Although I still say EJ is a great starting line. I do look for IVs after though. So Lucas, do you want to go on? What happened after? So you got your IO, you found your central line, then what?
Yeah, so I never mentioned our initial vitals, but her heart's fluttering from the 130s to 150s. Still, soft blood pressure is 100/64. She's hypothermic and still tachypnic. So we got the central line. I do like the idea of a dirty double. I just did a not full sterile central line. I did not put an A line, however, that would have been useful. I empirically, since we couldn't obtain an oxygen saturation, I also suspected this was due to hypovolemia, and she's young, very vasoconstricted. I thought she just needed fluids. And since I didn't know oxygen saturation, I called RT, and my thoughts were due to the vomiting to just empirically put her on high flow nasal cannula and just throw a non-rebreather mask over it. Just try to eliminate it as much as I could at the time until we get her resuscitated and could get a good oxygen saturation.
Lucas, do you have point of care labs?
Yeah, so we don't have point of care labs. We do have a point of care VBG, which we were able to obtain from the initial ultrasound guided IV that, like you guys said, inevitably blew as soon as the patient moved her arm.
Yeah, the reason I was asking is if you have point of care VBG, you have point of care ABG. I don't care that the machine, some labs block out the ABG setting on the machine. You just do it. You don't care in a patient like this that it's the wrong site. And then you'll have an immediate oxygen saturation on patients who can't read the probe. And that's the money move, is when you cannot get an oxygen saturation, you need an immediate ABG. And I see many cases where people just struggle and start treating with things like BiPAP or high flow, with the latter being safer. You can't go too wrong with high flow, and then they turn out, it's a hemodynamic issue, and the saturation was actually 100%. If you can't get a sat, you need an ABG, and you need that ASAP.
What were your labs, Lucas?
Yeah, so the initial VBG demonstrated pH 7.09, PCO2 36, PO2 on the VBG was 38. We did not immediately get an ABG. Bicarb was 11 and base deficit 18. The VBG potassium was 6.3, sodium 144. And Glucose, again, undetectably high, greater than 740 is where our VBG cuts off, about where it can read. And her lactate on the VBG was 4.3. And at this time, we are pressure bagging in fluids through her right femoral central line. And actually with that, improving her blood pressure a little bit and actually starting to get a oxygen pleth.
And I assume this patient, hypotensive, got ultrasound on her?
Yeah, she did. So the bedside ultrasound was largely consistent with hypovolemia, essentially underfilled LV, normal function, RV looked normal in size with no signs of right heart strain, no effusion. And IVC was essentially collapsible, honestly difficult to visualize in her. And then we also just checked Morrison's pouch real quick and no free fluid there, which was not unexpected.
Nothing surprising. And EKG done on arrival. Did the EKG precede these labs? Because we now have hyper K, but I would have worried about hyper K on this patient just from presentation. So what was the initial EKG?
Yeah, EKG did precede these labs as well. Sinus tachycardia, she had a right bundle and left posterior fascicular block. No big signs of hyper K.
All right, shadowbox for just a second on the description of the EKG versus Lucas's statement that there's really no signs of hyper K. Now this, imagine you don't have a potassium back yet. Just think on that for a second.
We had no baseline, to compare as far as like the width of her QRS. No peak T waves, however, the QT was normal, no ischemia or anything like that. When patients come into RED and especially like this, often they just get registered under a random name.
Yep. Though when I hear bundle branch block, that equals wide QRS. And when I hear wide QRS in a patient like this, I think hyper K until proven otherwise. In any patient like this, that's the one you got to worry about. But then paradoxically, you always have to worry about hypo K. And I see some people empirically start insulin on this just based on the glucose. And you can eventually go wrong. If this has been like a long-standing glycosiuria, these patients eventually waste down their potassium. And giving insulin to a patient with a K of 1.2 is not a great way to play. We've seen clean kills from that. So I like that you could have point-of-care labs. Now we know where we stand.
And then I think the labs came back soon after. Do you want to just sort of go over your chemistry?
Yeah, so the initial chemistry, sodium was 138, but corrected was 160. Her potassium was 6.2, so close to the VBG. Bicarb was 7, anion gap was 39, and the glucose was a whopping 1,451. BUN was 98, with previous being normal, and creatinine was 4.5, previous around 1.8. Calcium and magnesium. Calcium's normal, magnesium elevated, and phosphorus was 9.9. Formal lactate was 4.5. She had a white count, a normal hemoglobin, normal platelets, and LFT is largely unremarkable. Her serum osms were extremely high, 436, calculated, not lab ordered.
Yeah, the most concerning value was actually on the VBG. Okay, so what do you think I'm talking about? Shadowbox on that. What is the most concerning variable on that venous blood gas that we received already? Barnacle, if I had to ask you, pimping you now, you're back in fellowship. What number on that VBG is most scary to you?
Can I hear it one more time?
7.09, 36, PO2 at 38, bicarb of 11, and base deficit 18.
The most concerning value to me, I think, is the pH.
I don't know, man. Yeah, I'd give you that look I always give. Nah, the most concerning value on there is PCO2, because what that's telling you in this obtunded patient is that she is not compensating, and she should be. If this is pure DKA, there's no reason that PCO2 shouldn't be 15 or something like that. And the rule of thumb is it really should match the last two digits of your pH. Now, some of the older people can't get there, but they should be close. And 36 on her, that is a massive respiratory acidosis that shows that she is not compensating adequately for her metabolic acidosis.
And so I think this is where Lucas's case gets interesting, in that she was diagnosed with COVID as well recently. So we do have a chest X-ray, and it basically, it basically looks like a bit of an ARDS picture. It's just bilateral opacities, wet lungs. I guess as another discussion point is, should this patient be intubated? We've alluded to it before, GCS of 8, good 8, bad 8. With this patient with hyperglycemia, presumed DKA, HHS, would you intubate this patient? She's showing signs of respiratory acidosis. She's not keeping up, and she has multiple factors. So I guess what would you intubate, and what considerations or what modifiers would you do before intubation?
Okay, so you know the question coming now. Would you intubate? You want to start it up, Ryan, or you want me to?
Go ahead.
All right. I'd say definitely intubate. That's my vote. And that 36 is the reason why. I have nothing to lose at this point because if the patient had a PCO2 of 8, then it's really hard for me to maintain that. And I have to make a real judgment about whether I should lose some of the patient's endogenous Kussmaul compensation in exchange for some protected airway space. But I don't have any decision point here. I have an obtunded patient. I'm probably going to get some scans ASAP. I probably have to do some more procedures. And she's already not compensating. At 36, I could do a much better job than she is at, or he, I'm sorry, I'm messing up the gender, in getting that CO2 down than the patient's showing me. So now it's easiest thing in the world. And I don't have to worry that much. They're showing me that at 36, they can maintain 7.09. And since I'm going to augment that in the peri-intubation, I could probably blow them down to 20. Their pH is only going to get better. So yeah, this is the easiest one in the world to decide for me. I'm going to take the airway. What about you, Barnacle?
No, I agree. We've always talked about delaying intubation in these patients, but this patient needs the help.
Absolutely. So should we talk about how to get it done?
Yeah, let's talk about how to get it done.
All right. From a ventilatory side, if you had the BiPAP in the room, if Barnacle's call had actually gone out and they brought it, I might put the patient on BiPAP. Not from an oxygenation standpoint. We got a sat back by this point, though it certainly won't hurt to give them a little bit of PEEP, but from a ventilatory standpoint. So I probably put this patient, if I had a non-invasive machine, on like 15/5 or something like that to start helping them, augmenting, blowing them down. Now, if I didn't have a machine, and high flow is not going to help you much with this, so that's not going to be the win. If it's there, certainly keep the nasal prongs on. But what this patient needs in the peri-intubation is as soon as you paralyze them, and I would probably RSI this patient, especially if they respond to those fluids, is to actually be bagged during the apneic period. And you still got to be gentle. You can't bag them 30 times a minute, but certainly something like 12, 15 times a minute with reasonable tidal volumes will blow down that CO2 quite nicely. And that's the way to avoid a pH drop during an intubation like this. I would use ketamine. And I don't care about which paralytic you choose. So for me, it'd probably be rock. You can make an argument just because of general sickness to do an awake intubation. But for me, I don't know. I'd like to get that tube in as soon as possible and start controlling that ventilatory status. And I know an awake intubation is going to take longer. And I think the hemodynamics here are amenable to doing an RSI. Would Lou, Barnacle, you do anything different?
No, I think I would do the same. I guess my only question would be why rocuronium? Why not succinylcholine so that the patient could theoretically drive their own respirations afterwards?
He or she has shown me they're useless at that. They've already fucked off from their job. And like I said, I don't care. So if you wanted to use sucks, knock yourself out. But what I can tell you is I'm going to do a better job than they are during this initial period because they're not doing a good job. So might as well have a paralyzed patient for 30 minutes, blow them down, stabilize, and then let them take over.
Yeah, I think that's pretty much how we would all do it.
Yeah. Did she have any anatomic concerns that we talked about? I forget at the beginning what her general appearance was, but is she obese or anything like that?
Yeah, she was obese, not the tallest person. That's probably about the only specific anatomic concern we had. I think that's about it.
Yeah, I would just, as usual, be prepared with multiple modalities before RSI meds are pushed.
All right. So did you guys intubate at this point?
No, we actually did not. My thoughts with her current situation was, I knew she had some component of respiratory acidosis, but we also had, in the context of COVID, X-ray looking like ARDS, her hypovolemia, acidosis, all of that, with her still protecting her airway. Our thoughts initially were that if we get her on an insulin drip, we start to improve at least the metabolic component of her acidosis, fluid resuscitator, improve her lactate as well, we might be able to temporize her without intubating her. So we actually held off for the time being.
Yeah, you're rolling the dice. She is protecting her airway. If this was a pure DKA, you could almost always get away without intubating. It sounds like a mixed bag here. You're telling me ARDS. You're showing me an X-ray that's garbage. You're telling me the patient has a lactate of nearly 5. That doesn't seem like my typical DKA patient. And as Ryan and Christina will tell you, the rule is if you're sick, you get a tube. And if you're too sick to get a tube, then you get made better in order to get a tube. So I don't know. This is not the patient I would necessarily play the wait and see game. So many things happen once you intubate that are for the patient's eventual disposition rapidly occurring and actually things happening, I find a non-intubated patient becomes a kludge to doing things like getting to CT, getting diagnosis, getting immediate acceptance to the ICU. Once you tell them you have an intubated patient, they got no choice, and all of a sudden things move. Now, if you're in a place with an ED ICU, it might not matter as much, but if you're in a place where you cannot provide one nurse to two patient critical care, then getting them upstairs ASAP is really key. And the fellow coming down, and they wouldn't in a case like this, but the coming down and saying, let's see how they do before they decide to accept, I don't want to deal with that crap. Just some other priorities that are coming to mind here is I would give this patient empiric broad spectrum antibiotics. I don't care if that turns out to be pure DKA with an inflammatory state. It's not really on my priority list to not waste that one set of broad spectrum antibiotics. But then with a heart transplant, you haven't given us a med list yet, but I'd be giving this patient stress dose.
I guess as far as the case goes, Luke's alluded to that she ARDS, and there's a question if she's fluid overloaded. And I think she has two opposing treatment factors in that she has DKA. So typically DKA, she's in shock. We want to give fluids, but we also know that with COVID or ARDS, they like to be dry. So I think in her case, she's tricky as to how much fluid is enough. And so I think it'd be really interesting to talk about how do we measure that and how do you determine when to stop fluids or when to continue giving fluids?
All right, Christina already set the case question up for you. What is your thought? You want to start, Ryan?
That's the trick on every single one of these patients. I think you have a lot of evidence on that initial rush exam to show that she is volume down, and just the fact that she's in DKA for a fact that she's liters down. So I think there's nothing wrong with starting with a couple liters bolus. 2, 3 is totally reasonable. She's hypotensive. So I think those things, when you're trying to balance that against keeping an ARDS patient dry, those things don't need to be like the volume status, the low volume status is the priority at this point. The heart transplant, I'm wondering if that sort of factors in, but it sounded like she had good function on your exam. So there's really no reason to think that she can't handle it from a cardiovascular standpoint. And then her ARDS, we alluded to this already, but intubating her would make it easier to handle overshooting the fluids if that happens. So that's another thing to consider about intubation.
Yeah, I think you hit the nail on the head on all that. This patient needs a ton of fluid up front. And when they're no longer cold and their IVC is not flat, and they're not hypotensive, then we could reevaluate and say, do we want to be a little bit more conservative than we would be on a typical DKA patient yet? But you're not anywhere near that point yet. The kidneys are already shut down with a pre-renal azotemia. The longer we keep them in that state, the worse their eventual renal failure is going to be. This is an easy one. Yeah, I like your number. I'd say 3 liters right off the bat and then reevaluate. And for me, you could go back to the balanced fluids matter or not. They clearly matter in DKA if you don't want to give them an additional metabolic acidosis, and this patient doesn't need that. That's a whole separate study than basics and plus and whatever. So give them a balanced solution, give them LR, 3 liters in, and then reevaluate. Are they now warm? Are they normotensive? The IVC's filled? Reassess the heart function, and then ask yourself, do I want to put them on a slow or rapid continued DKA fluid regimen? But not at this stage of the game.
So then I guess once the 3 liters go in, let's say they warm up a little bit and hemodynamics improve, how do you determine when to stop? When is enough?
Yeah, in the DKA, they're so fluid down. And with the 1400, this patient's so fluid down. So I don't think you have to worry in the ED about when you're going to get to enough, because you're not going to get to enough. All you have to worry about is how rapidly you want to give them in. And if the patient starts stabilizing, then I think pulling back to something like 250 cc's an hour is just fine, because no matter how long you're going to keep them in your EDICU, you're not going to get this patient's total body volume loss down to the point where you could stop fluids.
Okay. And I guess maybe it's worthwhile, just for the sake of this conversation, just to talk about treating DKA in general. Is there just, for the sake of the listeners and just going over what's at core of this case is just talking about bread and butter DKA treatment.
Yeah, we could do an entire podcast on that, and I have, but On this patient, getting insulin in is a priority. And I hear some people talking about DKA and they're like, oh, I'll give the fluids first and then reevaluate and then decide if they need an insulin drip. Yeah, that's someone with a sugar of 300 and like the most mild of ketones. That's not this patient should get a bunch of insulin right up front. We would start with the Stony Brook protocol by giving 0.14. It's not necessarily any better than 0.1. The 0.14 is probably better if you're not going to give a bolus of insulin, though at most places I've discovered that ordering insulin is not the same as patient getting insulin. And there's oftentimes a requirement because it's a high-risk JCO medication of it being made in the pharmacy and sent up. And that could take an hour and a half. So on a patient in this circumstance, then give some subcutaneous or IV, Lispro or regular insulin to get them started and then get the insulin drip started as soon as possible. And they will absolutely need potassium repletion once you get that initial K treated.
How do you feel
my
about
thought is like, we're gonna treat this DKA, like that's not questioned, and it's not necessarily something we need to rush, or like we're not trying to turn them around and get them to the floor. They're going to the ICU no matter what. So I would just follow the protocol. Don't try to get fancy in this situation because the patient's otherwise got other problems.
And what Ryan's actually saying, I think, if I translate, is you should have a protocol. You shouldn't be inventing this de novo every time you get a DKA patient. It's totally worthwhile to just make a protocol with your ICU endocrinologist and ED that all of you could agree on so that there's not arguments and inventing this stuff on the fly. Is there any other decision points, Lucas, or can we hear how this case resolved?
Oh, did we successfully treat this hyper K too, with those EKG changes?
Yeah, so we did. We started with 3 grams of calcium gluconate. I probably just could have given chloride. I had a central line. I don't know why I didn't think of that. But we did treat the hyperkalemia as well.
Did it change their EKG at all?
Yeah, her EKG got more narrow. She actually, interestingly enough, when I was doing the central line, we were limited as resources during this case. We had multiple traumas rolling in. This was pretty early in my residency, and it was just me and fresh intern in the room. And she had this random, probably SVT with the right bundle branch block, which we knew she had. Heart rate went from 180s. And at that point, we had already had our VVG back. And that's when we pushed some calcium. And it actually spontaneously resolved, never happened again. By the time we got pads on and everything while I was doing the central line, she's fine.
Yeah. On a patient like this, sure, it could be, though at 6.3, I doubt it. It's more likely to me, given the case, that it's a magnesium issue. The thing about serum mag is, A, it's totally useless, but on a severely volume down patient, it's even more useless. And my guess is this patient is total body mag down. There's no way that she couldn't be. And yeah, absolutely, you could give calcium. In fact, you should, just as you say, but I would give magnesium to that run of SVT as well.
And as far as I'll get through with the rest of the case here soon, but my big question in her is, I would call her like a mixed DK HHS. We did send a beta hydroxybutyrate. It was significantly elevated. But she also, it's clearly in a hyperosmolar state. Do you have any concerns about osmotic shifts in someone this age with that high of a glucose and hyperosmolality?
I'm not sure why you even call her HHS, though. You could have crazy high glucose in DKA. I think for me, it's either they're making ketones or they're not, which means is there some degree of endogenous insulin or not? And she clearly did not have endogenous insulin. Did she have a history? We never discussed PMH because she was obtunded, but eventually did we find out that she have a history of insulin-dependent diabetes?
Yes, type 1 diabetes, actually.
Yeah. So it's DK in my book. Do I care about fluid shifts even in HHS? Only if they're a kid. And even then, the evidence is really back and forth, but no, I don't give a crap. Do I want her to drop from 1,400 to 200 in the span of 2 hours? No, but that won't happen with any reasonable protocols we use. It's just not possible. 1,400, the problem is going to be how long it takes, not how short. So I don't care about that.
And we kind of talked about giving broad spectrum antibiotics, but I wouldn't hang my hat on the COVID diagnosis without kind of pursuing a full infectious workup as well. I don't know if you guys found anything else during the course of the workup.
Yeah, so we sent a full infectious workup. We sent blood cultures. We started on broad spectrum antibiotics, probably within 30 minutes of her getting there, knowing that we didn't know exactly what was going on. We weren't going to hang our hats on that either. She didn't look like she had a urinary tract infection. She had a negative UPT. Cardiac enzymes were largely unremarkable. And like you said, we covered her with broad spectrum antibiotics.
She also needs her transplant team contacted within the first hour. So the ED, they're going to be pissed, and you don't want their being pissed to be at you. You want it to be at a situation.
Yeah, interestingly enough, she wasn't actually transplanted at our hospital. So We did contact our transplant team, and she went to our cardiac ICU. But yeah, interestingly enough, not local.
All right. Christina, are there other things we need to hit?
No, I think we got through all the big talking points of the case.
Yeah.
It's a really interesting case of a patient with multiple complicating factors, just to add in a little spice to the case.
Yeah, it's fantastic because like when you think about it, this is like a bread and butter case. Sure, they have a heart transplant and the COVID stuff, but I think people are not thinking enough about what they consider bread and butter cases. It's so much of what we try to imbue during the fellowship is that there's really no limit to how deeply you could consider what many people think are picayune small issues, and that those are the ones that actually have an outsized effect on patient care. So that's my thoughts. I love this case. Ryan, concluding thoughts?
Sounds like you guys did a good job. Did the patient ever get intubated? Did we say that?
No, that's the $1 million question. So probably about an hour and a half in, she started coming around, following commands, improved hemodynamics, perfusion on exam. She was transferred to the ICU and got an A-line there. She actually didn't get intubated. She's actually ended up doing well. Mental status continued improving, ended up being transferred to the floor, actually. Her oxygen requirement actually decreased as well. Interestingly enough, because I was obviously, like we talked about earlier, concerned about the fluid resuscitation in the context of COVID and ARDS. But she actually did really well, never required intubation.
Fantastic. Wow.
And so do we just think it was COVID that caused her to tip over into DKA?
Yeah, so we did get some further history, and she was seen at an ED for her, and it was a little bit probably around a week before, and she started on steroids, I think, when she got diagnosed with COVID initially. And so probably a combination of steroids, poor PO intake, and COVID-19.
We didn't mention it, and I don't want to vac shame this patient, but unless she was advised by her transplant team, don't get the vaccine, I think it's friggin' crazy for someone with a heart transplant not to have been vaccinated for COVID. You obviously show you trust the medical profession enough to get a friggin' new heart. You got to trust them to get vaccinated. That's just insane. All right. Finish us off, Christina.
I think we covered a lot of the great things about this case. I think Lucas did a great job with the resuscitation, and I really loved it just because, like you said, it's got all the little factors that we always have to consider for any resuscitation. There's always, I guess that's the art of it, is there is always these tiny details. Nothing is so much cookie cutter, kind of formulaic resuscitations. Everybody has something different. And I think we touched upon all the nuances of this case. And I'm hoping that the listeners out there also got something out of this.
Love it. Love it. All right. Fantastic. So if you have questions or comments, put them in the show notes for this episode. I can't thank our discussants enough. Lucas Goss, Ryan Barnacle, and the inimitable Christina Liu. Guys, this was so much fun, and I can't wait to do it again. All right. There you go. Amazing. If you want to see the full case write-up with images and learning points, then go to emcrit.org/322. And please, if you have comments about the things you just heard, we want to hear them. We want to hear disagreement. We want to hear thoughts. We want to hear additional stuff you have to add. emcrit.org/322. Scott Weingart for the EMCrit podcast, thanking my guest and saying bye-bye.